And here we go.
I didn't sign up, so.
Yeah.
Great. And well, good evening. Are we on, Jamie? Yep. Thank you all, and sorry for the delay in starting this evening, but a huge welcome here to the Blavatnik School of Government, to those of you masked and distanced in the room with me, and to all those of you joining us online. It's a huge pleasure today to be hosting someone who was announced this morning as one of the 8 honorands of Oxford's honorary doctoral degrees. It's an honor given to a very small number of people in the world, and who better than Dame Sally Davies to join those ranks. So I want to start, Sally, by just saying a huge congratulations on that. We're absolutely thrilled that you're going to be honored by Oxford University in this way. Professor Dame Sally Davies is a member of the International Advisory Board of the Blavatnik School of Government. She was Chief Scientific Advisor for the Department of Health from 2004 to 2016. She was Chief Medical Officer for England and Chief Medical Advisor to the United Kingdom government from 2011 to 2019. It's a role we're now used to seeing on our television every night, but it wasn't always that way when Sally was in the role. But she played a huge role in Britain, establishing and founding the National Institute for Health Research and other parts of the government machinery on health. But I think the thing that Sally Davies is most known for is her absolutely energetic and ceaseless advocacy for the world to do something about antimicrobial resistance and AMR, and to save the world from a fate that it's rocketing towards, with too few people championing the cause with the same energy as Sally. She is now the 40th Master of Trinity College, Cambridge, from where she's sitting and addressing us this evening. And Sally, you have just produced a book. Whose health is it anyway? So why don't we start by you telling us, why did you write the book? Who is it aimed at? And what is it that you hope people will do once they've read the book?
Thank you. And it's a great pleasure to be here with you, Ngaire. And I am incredibly honoured by Oxford University. So thank you. I look forward to the ceremony. I'm sure it's going to be great. So I was Chief Medical Officer, and one of the pleasures of being Chief Medical Officer, there are lots of downsides, but the pleasure was writing my independent annual reports that were a statutory job, and one that I produced in December 2019 was about what could health look like in 2040. And I came out of the process of preparing this and getting experts to write chapters and then writing about the policy part of it, very enthused by a number of things. The first is that health is our greatest asset as people, as communities, as a nation, not just for health and happiness, but actually for our economy. And there's a very nice chapter done by the IFS, Paul, who shows how now being in health rather than physical unhealth or even mental ill health that stops you from working matters more to your employment prospects than your education. And we looked at a number of things, and I began to really by then to have taken on board all the issues about inequalities and how inequalities play out with poor health, and therefore it's not fair. And then I left in September 2019 to move here to Trinity, and my colleague, who was the chief editor, had persuaded the Oxford University Press we should use the themes in our report to write a book, but COVID hit. And what we all saw was the unfairness, how the most deprived were the ones who had the most fragile jobs, who if they stayed in work had to travel more and caught COVID more, who died more, who had more comorbidities that raised their risks. So what we did was Johnny Pearson Stuttart and I was sit down and write the book at a great speed. So we finished at the end of July, because what we wanted to do was talk to the world and influence thinking about what is health, first of all. If you're going to value it, you need to know what it is. And we talk about total health. It's not just physical health and mental health, it's social health. And then looked at why did we do badly in that first round of wave of COVID. You need resilience, you need personal resilience, you need health sector resilience, you need economic resilience, and what was missing, and the impact. And then we went through a number of things and ended up saying, so we've got to value total health differently, and here are our ideas for how we as a nation should go forward. You can talk about building back better or whatever, but that health shock, economic and social shock, if we don't use now to make it a better, safer, fairer world, then when are we going to do it?
Mm-hmm. So it's a call to action?
Yes, yes, it is. And it's
would
very
you
interesting that I thought the private sector would find one of our suggestions really very difficult. So we called for a national health index, and I actually called for that in my December 2018 report. And now the Office of National Statistics has published a beta version on December the 3rd of a national health index that they've consulted on, and we're expecting it later in the summer as a national statistic by GDP. And we can talk about that more, but essentially what gets measured gets acted on. So I'm thrilled about that. But what we also argue for is a national public health investment fund. And I don't think that should just come from taxation. We actually argue that the private sector needs a healthy workforce and doesn't want the economic shocks we've seen, so they should contribute. And we argue that they should, and it's an economic model called play or pay. If they don't look after the health of their workforce, their families, communities and society, then they should contribute into a national public health investment fund so the money is there. And if they produce and make profits from products and services that are bad for health, then just like the sugar levy for soft drinks, they should pay a levy. And we recalled the days of Cadbury's building Bourneville Village and Fry's and the other Quaker movements that really did recognise the need to invest in worker and community health, and how we've got to go back to understanding that we all interact and private sector has a big role in people's health.
Mm-hmm. I mean, Britain's quite a standout country in the world because of its universal healthcare system, the National Health Service, of which Brits are inordinately proud. And right up until the COVID pandemic, most of us were led to believe that this was your best insurance against a pandemic. If you had a health system with universal free access, you were pretty well insured against a pandemic. So, and I think, Sally, you're one of those advocates of universal healthcare. So why did it all go so wrong? Why in this country where every citizen has access to healthcare, did it go so wrong in that first phase of COVID?
Well, I think it is multifactorial. First of all, when it was set up to treat people's ill health and look after women in pregnancy, which is not ill health, and giving birth. But it's become a national illness service. It doesn't look after people's health and keep them well. It doesn't reach out to those who find it difficult. So what we've in effect done, and I'm very proud of it, I've given my life to the National Health Service, is actually ensure through taxation a national illness service. And, you know, it did pretty well in each wave, but what we saw was the lack of resilience. And I've never forgotten looking at the data, which I kind of knew, but it was very stark, of OECD investments across all the countries on doctors per population, nurses per population, beds per population and intensive care unit beds per population. And we were right down in the bottom 3 on everyone. So we were delivering really good illness service, but as we knew from every winter when flu was there, it had no resilience. We had underinvested in resilience.
So are you saying you knew already, even when you were chief medical officer, that we weren't ready for a pandemic because our flu system wasn't working?
No, I was saying, I'll have to frame it more carefully, won't I? That we had very little resilience and that we ran the NHS very hot if there was bad flu. In fact, the 9-10 flu pandemic, the swine flu, probably lulled people because we did cope with that. But no, we did not have the resources we needed for this pandemic. But then no one has either. But we've got to look at how to improve and learn the lessons, but I don't think we should beat ourselves up dreadfully.
Yeah, but with the huge benefit of hindsight and recognizing that it is with huge benefit of hindsight, what would be the top 2 things you would have done differently if you had been in government over this pandemic?
Well, I mean, we clearly should have locked down earlier, but the one that I worry about is mask wearing. People don't seem to want to wear masks, and we've never had randomized controlled trials, but you don't need them. There is a terrific amount of research that masks work for respiratory illnesses, and we've proved it this year. We've had next to no flu and not many colds. And we were late to pick it up, and I think we're relaxing too early. So I would go for that. But of course, I argued for it all along in my time as a CMO, we should have done more on prevention of ill health, and we should have invested more in the NHS. But we had times of austerity and it didn't fall over even in a hot winter.
Can I invite the audience, by the way, to put questions either on the chat or if you're in the room, just to wave a hand. Because I think having sort of talked a little bit about COVID, in a moment, I'd like to move on to talk about AMR and Sally's work on AMR. So any questions on COVID? Anna?
Hi, I'm going to try and boom, but tell me if you can't hear me, Sally.
I'll repeat it so everyone can hear it.
So you just mentioned austerity and times of austerity coming out of presumably around 2009. When we look at the data on the fiscal impacts of COVID, comparing 2020 with 2009, 2020 blows 2009 out the water. So what does this mean for austerity and in particular in the NHS going forwards, and the practicalities of what you would like to see?
Well, it bears out what I said for many years, which is if we get a bad pandemic, we're going to be in a mess. And that I think nobody realized how big the economic mess would be. I think that's caught everyone napping, but it's shown that we need to think about how we ensure that we're insured in some way, or insured to ensure we can respond effectively. And it does mean we've got to invest in public health. It does mean we've got to help people have good lives. And it does mean we need a resilient health service. So, and that all takes investment. So how are they going to find the fiscal space and not move back into austerity? I'm hoping everyone will be scared, too scared to go into austerity. But my concern is that for a while, there'll be investment for 4 or 5 years, but then politicians will forget, and that then it'll drag down again, and they'll have forgotten the issues. So I think we'll get short-term investment. I hope we get long-term, but that's why I think we need some real structural changes and recognition. I mean, this talk of leveling up in the north. Yes, let's do it. But hey, make sure you do it through providing health and education and employment. Those are the three things we need, and then we're all there. Don't do it just by a bit of tokenism on infrastructure.
Yeah.
Thank you so much for joining us. I just wanted to pick up on something you mentioned, I think, a couple times. And you said that you were worried that we're reopening too early. I was wondering if you could elaborate on that.
Sorry, we did what too early?
Opened up too early. And do introduce yourselves when you ask a question. So Henry from Canada, asking.
I think you had mentioned that you worried that we were reopening too early. And so I was just wondering if you could elaborate on that.
Yeah, are we reopening too early now?
I didn't say that. I said we closed too late. Are we reopening too early? I don't see all the data that SAGE sees and the government sees. But I am worried about this Indian variant. If it is 40 times more infectious than the Kent variant, which seemed very infectious, then I think with vaccination levels where they are, we've got a fabulous program, but it's still not where it needs to be. I think we do need to be concerned and consider local lockdowns and watch it. I mean, I still remember last summer watching Bournemouth Beach and saying, oh no, what's going to happen? And then I went asking about a month later and said, have we had a peak in hospital admissions and things? And we didn't. And that's now borne out by the evidence that if you're outside, the risks are pretty low. But there's very nice data, movement data and infection data put together that shows that pubs, restaurants, hotels are risky. I have to tell you, I'm going to go on being careful, even though I've had both vaccines.
And Sally, did you say that you're worried that people are relaxing mask wearing too early?
I think there is a risk of that, yes.
So keeping up that protection. Any other questions? Yes.
Hi, so my name is Julia and I'm from Canada. And my question is about kind of the translation of evidence into policy with your experience in working in the public sector. I took a lot of interest in reading about Operation Cygnus, which was like a pandemic preparedness simulation in 2016 that I know a lot of recommendations came out of, and that you were very involved in those recommendations. And then we've just seen the independent review of the WHO with a lot of recommendations. And I suppose my question is what you would recommend for government and policymakers going forward to make sure that recommendations coming out of this pandemic are put into practice and don't get wasted, I suppose.
Mm-hmm.
So there are a number of things wrapped up in that, Julia. The first is who's making the recommendations to whom and what's the accountability. So for Cygnus, the recommendations were made within government to government. So you expect them to be acted on. And indeed, the Tory party would say that they got some extra money for the winter and for the NHS as a result. And there was quite a lot of kind of policy development that happened and linkage and actual work on the ground. I mean, one of the things that was clear was that if we had a really bad flu pandemic and with a lot of deaths, we did not have the capacity to cope with the bodies, for instance, and work was done about that. Whose responsibility? So what are you doing? And at the height of COVID, you saw some of that playing out, that people may not have looked prepared, but there were plans to be dusted off. If you move to the WHO, take Ebola in West Africa, there were at a minimum 5 reports on it. Maybe one was commissioned by the WHO. Well, most of them were motherhood and apple pie. But you start to say, even if it's a good idea, it's a group of independent people, why should anyone do that or something else? And though if you charted them, which we did, you could see there was commonality. Where was the pull to do something? But then if you move forward to this recent review, that was commissioned by WHO, so they ought to listen. But then you get into the complexity of the WHO, that it should be funded by contributions from every country, 180 something, I think it is, according to their GDP and an algorithm. But there are some countries that never pay. Others, the Americans, pay most. After the Americans, I think it's the Gates Foundation, and then we come pretty high. I think we're the second highest government. Germany and France come in beneath us. But a lot of the money given, not by the Brits actually, but by other European countries and people, is very tasked. I'm giving it to you for this purpose. So they're short of money. Much of it's tied for various programs and not prioritized. And they have no effective way of saying, this is our priority, and that's important, but actually we're going to drop it. So it becomes a very difficult business, whether they want to do what that report says or not. Who are they accountable to? An executive board that doesn't truly, I've sat on it for 3 years, hold them to account. Their funders can hold them to account a certain amount, but it's not effective. They don't know how to prioritize. So it becomes very difficult. And I'm really disappointed because when Tedros was elected as Director General, he beat a British candidate who I was running. I thought he would be good, and he had the right ideas of reforming within the organization and how it worked. And he's not managed. And if he can't do it when we were all wanting him to, supporting him, and he had the right ideas, you know, there are still people in there working in their expert technical silos who refuse to accept that that might not be a priority at the moment, that maybe they should do what this external group says. But he doesn't manage to find traction on his own staff. He doesn't really have much of a budget. It's a real problem. So I've told you all the problems, and the solution is that everyone pays their subscription that they're supposed to pay and doesn't tie anything. And then you begin to get some movement, because then the leadership should be able to do something about it. But I'd finally...
Thanks, Sally. I'm going to throw you the next question because, I mean, even the UN independent panel, yes, they're arguing that changes need to be made at the global level, but also every review so far is saying national preparedness is important. And Aisha Farouk, who's on in this seminar with us online, asks, what are the key lessons you would draw from the COVID pandemic and your country's preparedness to prepare better and more effectively for another pandemic down the road? So a couple of key things Britain needs to get right to be pandemic prepared.
Data. We were not prepared data-wise in the health sector, the health service, how you aggregate it, track it, learn from it. We definitely weren't prepared in the public health sector, nor did we bring together the data, behavioral expenditure, mobility from the private sector until recently. So I'd start with data. I am proud of how we did clinical trials, but then it was NIHR infrastructure that made that happen, and I set it up. So of course I'm proud, but we've provided answers for the world. The other thing is supply chains. You know, governments have not taken a big interest in supply chains. There's a market, you buy. But it is quite clear that the supply chains were fragile. When we move on to antimicrobial resistance, I can talk to how fragile they are for antibiotics, and that they generally, for PPE, for drugs and things, started in India or China. And really, I had been saying for some years that we ought to repatriate some manufacturing of drugs. And I think now we need to look at our supply chains and think about vaccines, maybe not make it all ourselves. I don't think we can afford to, but with friendly countries, have we got enough factories and strong supply chains that we can all get the stuff we need? And do we then make sure we have excess, significant excess for low-income countries?
Mm-hmm. Sally, can I just pick up the first thing you said in this answer, which was about data? Wasn't the lesson around test and trace that everybody obsessed about data and apps, when actually the evidence from around the world is that you need to have somebody who you trust knock on your door? What's the balance? What did you mean when you just threw out data?
I think you can't plan and you can't model without data. If you're talking about what's going on the ground, we know that in this country, the most effective way of doing it has been to use our local public health teams and environmental health teams who are used to tracking and doing that. I think if we'd got that working early, then we would have been in a much better place, and then we could have debated with the public whether we could move into a more app-style situation. But we started the wrong end of that. And indeed, we never really had much debate with the public. I was talking with Lord O'Donnell at something about our book, actually, about the National Health Index. And he and I both feel that health and life and death has totally dominated the discussion. We haven't really debated isolation, depression, loss of jobs and economy and the whole issues in our response. And yet, we probably should.
Mm-hmm. Another medical question from Tatenda Magetsi, who asks, to what extent can we trust that reaching herd immunity will protect countries against COVID-19, given that Seychelles, the most vaccinated country so far, has still seen a rise in COVID-19 cases?
I think it's very worrying, this idea at the beginning that herd immunity was what we were after and people thought it would be 60% coverage, when we know that for measles, you have to get to about 95%. For smallpox, you had to eradicate every single last case. I think that immunity in the population from vaccines and former infections is very important, but variants can cut through that easily, and very few are going to have high enough coverage of infections and vaccines to give full herd immunity, is what it's beginning to look like. That may be a lost cause.
Mm-hmm. Francis Butcher asks, could you define health security? And writes, I've heard two quite different conceptions of this term. The first is about protecting populations from health threats, like pandemics or AMR, while the second draws on conceptions of human security and human rights, where health security is about the right to receive healthcare. How would you define health security and global health security priorities?
Thank you, Francis. So, I recognize the importance of human security and human rights, but if you start from a rich country perspective, well, no, maybe it's not a rich country, but if you start from a British perspective, it's more the health threats that become the health security issues that we debate. So we would meet with like-minded countries around the world, but particularly European Union, the States, Canada, Korea, and places, talking about threats to health as health security. And that might be infectious threats in the food chain too, or infectious threats in, or chemical or other threats to our environment that could impact us. But they are all threats to health, because we take as a basis of our discussion that there is reasonable, I'm not saying perfect, human rights and human security.
There we go. Anna, you've got another question.
Hi, Sally. Sorry, I should have introduced myself before. I think we know each other already, though. I'm Anna. I'm co-PI on the Oxford Tracker project. You said a moment ago that herd immunity might be a lost cause. And I find this interesting and very worrying, because for me, the most dangerous thing about this virus is the fact you have asymptomatic people, which suggests there's little or potentially no evolutionary pressure for the virus to become less infectious, less deadly over time. So if herd immunity is a lost cause and we are in this very sticky situation with such a dangerous type of virus, what does the future look like? Are we going to have some version of social distancing for a really long time? What do you imagine?
And can I play in a question by Roshni Mansingh, who said that the WHO has said that COVID in 2021 will be far more deadly than in 2020. So it's raising those similar issues. Sally.
So it may be that someone knows the answer to your question. I think they can only model it, but where do I think we're going to end up? Well, right at the beginning, I said we will have 3 waves and we're coming to the end, I hope, of the second wave. It may bounce up because we're coming out too early or the Indian variant is there. I think we'll have a 3rd wave in the winter. The question is not will we for me, it's how high, and that depends on variants and vaccine levels. And don't forget, in 2018 flu, more died in the 3rd wave than in the previous waves. Where do I think we're going to end up? Endemic COVID, where, like flu, every season there will be the frail, the elderly, some of whom catch it either because they aren't vaccinated or they're very unlucky or they're immune suppressed, who die of it. And I hope that it will become so endemic that it is few. Of course, in countries that can't afford the vaccination or it's too complex, you're going to see it ripple through much more, and that will then impact on livelihoods and on the economy. And I think it's very worrying. I think we will get to international travel, but it'll become much more around countries that are vaccinated. And I worry about countries that are low and middle income, where they want the money from tourism, but actually haven't been able to vaccinate because we haven't been generous enough from the rich countries, or we haven't had enough production, or when we make it available, by then there are new variants. So I do see a rather bleak future in some ways. Let's hope I'm wrong.
And for the non-scientists among us, from Anna's question, does this virus become more lethal from now on?
I don't think it needs to. So, and the point that Anna made, which was absolutely right,
was the opposite.
because you're infectious before you die, before you get clinical symptoms and die. It doesn't need to get worse. Mm-hmm. So I think it may well just be chance.
Mm-hmm. Then there's a question that takes us back to the health service. Maria Moore, research nurse from the Liverpool School of Tropical Medicine. Hi, Maria. Who writes, do you feel the fragmentation of social and health care has contributed to the lack of resilience within the NHS?
Well, the way social care was run and the interaction between the NHS and social care clearly did that our NHS could send infected patients out into social care, and there was no PPE and everything, I think is very distressing once we knew what was happening and we saw lots of deaths. Is that the privatization that allows that, or the fractioning? I think it's lack of thought that makes that happen. So I do worry about that. But I also worry about the fact that at the moment, while most elderly people in social care are vaccinated, there's still a very high proportion of social care staff who are not accepting vaccination, and that is a worry. Whereas we have a handle on vaccination in the NHS, we do have some mandatory vaccinations, things like hepatitis B. We don't have mandatory flu vaccinations, but Before I left, they were already saying if you won't have a vaccine, you can't work in certain areas where the patients are high risk, because we had evidence of patients catching flu and dying. And I imagine that they're going to be doing very similar things with the COVID vaccination, but that we can have private social care or local authority social care where under half of the carers are vaccinated, I think is scary.
Sally, could I move? Because the whole world is so focused on COVID at the moment. But a couple of years before COVID, you hosted a meeting that I was at about AMR and the threat it posed. There were very eminent people standing up and saying simple surgery might not be possible for human beings in a few years' time. This is absolutely game-changing for all of us. So has everyone taken their eyes off that ball at the moment, I guess is what I'm asking you.
Well, I suppose all but the aficionados may well have done. So if I look at it, I talk about a lobster, and I think COVID is the acute pandemic with the lobster dropped in boiling water, making a racket and dying. Antimicrobial resistance, AMR, is the lobster put in cold water being slowly heated up. It's not making any noise, but it's dying. And we know year on year the deaths are rising. Indeed, the most recent survey of oncologists in the UK show that 1 in 5 oncologists think that AMR is going to be the biggest problem for cancer in 5 to 10 years, because they can see a time when they can say to a patient, well, modern therapies, we can likely get you a cure, but we'll knock your immune system for a period, you'll get an infection, and we don't know that it'll be treatable. And if you look at the data, year on year, it's getting worse. The WHO recognizes it's important. In fact, early in 2020, at the beginning of 2020, they published a document with their top 10 threats in health. One was a pandemic, the other was antimicrobial resistance. And they have set up a global leaders group, which I'm honored to sit on, with people for the UN from around the world, but it's proving difficult to get everyone to agree to do the actually quite difficult things that need doing, you know, stopping using antibiotics.
What are the most important things to do? I came along to the meeting that you hosted a couple of years ago thinking that this was all about getting doctors to stop prescribing antibiotics for people, you know, Oxford students with colds or something. But the first thing I heard at that meeting was that 80% of antibiotics are used in agriculture, which made me think, well, it's probably not the doctors we should be talking to. It's the vets and the farmers and the agricultural business. So, but in your view, you know, as one of the world's expert group on this, what are the most important and urgent things that need to be done?
We have to conserve the drugs we've got. So we need better diagnostics. We need to not overuse them in humans, but not overuse them in animals either. So they're used for growth promotion. They're usually tipped with feed into aquaculture, fish farming. And as you know, the biggest growing protein area for human nutrition is fish farming. We need to do something as well, because of all this overuse, about the environment, because animals pee or poo out, and this includes fish, humans, pigs, whatever, 70 to 80% of antibiotics, which are very difficult to break down. So they're going into our water systems and our water tables and the rivers and seas. So we've got to use what we've got better, but then we need a mechanism to persuade pharma and biotech to invest in developing new drugs and bringing them through to market and keeping them on the market. And they're not doing that because we pay too little for drugs.
And is there a clear link between the use in agriculture and human resistance?
Not as clear as you'd expect. So there's evidence of transfer from chickens and pigs and things, but it's not as clear as you'd expect. But this is somewhere where you have to follow the precautionary principle as well as working with the human sector.
And so on this issue, can you give us a little glimpse of what global cooperation or not looks like? I know that only a few years ago, some of the last line of resort antibiotics were being used in Chinese pig farms. So presumably this global effort includes China, it includes the United States, which massively uses them in agriculture as well. Is there genuine cooperation? Like what does that look like for us?
Well, it's beginning, the cooperation is beginning to happen, but and everyone recognizes the need for new drugs, better diagnostics, and looking after what we've got. And of course, access. More people die of lack of access to antimicrobials, particularly antibiotics, than die of AMR at the moment. It's just, it will inflect at some point in the not too many years. But getting every country to agree to remove antibiotics as growth promoters, to remove antibiotics instead of clean fish water and using vaccines is hard work, because they will have to invest in much more infection prevention and control in the animal sector, the fish sector, and of course, you know, streptomycin, the last resort drug for TB, and a horrid one, is sprayed on citrus crops in California and Florida for 2 weeks every year to prevent citrus greening. What we need is some serious GM, that they develop citrus trees that are protected from it, so that they don't need to do that.
And then finally on this from me, and then I'll open back out to questions. How do we both ensure that in the wealthy world uses less antibiotics, and at the same time, we get more antibiotics to the populations that genuinely need them and who are, you know, dying because of a lack of them?
Well, then you come into how do you deliver universal health systems and strengthen the health systems. I persuaded George Osborne to give us 265 million of aid, and we're helping laboratories in 24 low-income country nations develop their testing, good for patients, and their surveillance, so they know what they can do and what they need. But what we have across the world is very shaky delivery systems, and some of the old antibiotics are not available. Meanwhile, for some of the new ones, the companies just are not bothering to register them in low-income countries, because to register a drug in a country means you've got to have a special package, a special insert, go to their regulator. It costs too much. They're not prepared to. Indeed, there are at least 3 new antibiotics, I'm told, that are not registered in the European Union because it's just too much effort and too costly.
Wow, that's sobering. Any questions? Yeah, Myrta. Do introduce yourself.
Yes. Hello, my name's Myrta. I'm half Dutch, half English. I think this is so interesting because I come from like a climate policy background, and I see so many similarities with basically prioritizing the present over the future, prioritizing kind of marginal, unimportant gains that are causing existential threats. And I'm wondering what you think someone without a background in health policy can do to help kind of solve this problem or facilitate global cooperation, or anything you think that, I guess, someone from outside health can do.
Well, thank you, because I think it's very similar to climate change in its complexity and in the intergenerational issues. You know, my generation and older have had the antibiotics, the antimicrobials. Your generation and your children, unless we sort it, are going to have a real problem, and it will impact food security and things. So we need to have you think in that climate way. How do we show that this is a pandemic that's happening, albeit slowly? How do we raise political awareness? And it's in all these bits. I have to say, I'd only started working on the on the environmental side about 18 months ago. It took me a long time to understand that. And one of the things that we're doing now is working with some investors with a particular charity called FAIR, F-A-I-R-R, the Principles for Responsible Investment set up, the Kofi Anand set up, and with Access to Medicines NGO, about trying to get antimicrobial resistance into ESG, economic, social, and governance issues of companies, because, you know, consumers can have an impact, but so can investors in a big way. And my students here in Trinity have started a student activist group using our endowment, which, as you may know, Trinity has quite a decent one. And McDonald's are responding to their questions, and we're getting, and Yum Yum have. So we're beginning to push both through FAIR and in the student activist way. And I think that you can all play a role through consumer. You should look. Why would you buy a burger, if you want to eat a burger, from somewhere where the meat will have had growth promotion antibiotics? You don't want that. You can do it through your pension funds or student activism in other ways.
Mm-hmm. Yes.
Hi, yeah. I'm Daniel. I'm from Canada as well. And my question was about the drug development pipeline again. You mentioned that, you know, and it's widely known that, you know, the financing for antibiotics is not as advantageous for drug companies, say for the newest oncology drug, you know, or rheumatologic drug. Is there space to be inspired, you know, by the rapid COVID vaccine development and see a role for government to come in and incentivize some of the activity in the drug development pipeline?
I think so. It's interesting that Melinta and Archaeogen both went bust and both had decent new antibiotics. So, and Archaeogen's they were both registered with the FDA. So they'd gone through the worst, but they still couldn't turn a profit. So one of the things that we're doing in England with the NHS is we're trying a pilot of 2 drugs. There was a competition for which drugs we do. One belongs to Shionogi and the other to Pfizer. And we're looking at how we could value them instead of with a standard health technology assessment of life years and quality life years, but value it in that way, in the advantage of having the drug on the shelf to the NHS and to society much broader. And based on that evaluation, then paying a subscription to the company, we could nickname it the Netflix, because this is what will pay you. It's the value of this drug to our society. And then doctors don't have to use it. It's totally de-linked what we pay for it as an NHS from the amount used, because of course overuse drives resistance. So more of that can be done, and we're working through G7 to try and get the other G7 countries to agree to the principles of valuation to see if they can find ways of trying out and piloting different incentive mechanisms. But we are going to have to pay for them in some way or other. What I don't understand about the companies, and I've said this to them, well, I've told them that they've got blood on their hands at the moment, is there they are turning out anti-rheumatic drugs or anti-cancer drugs. And actually, if the patients can't be saved from infection, their product line is dead. I mean, think of me if I'm told tomorrow, okay, Sally, you've got cancer. It's what I said earlier. And one of my friends in India says this to patients. You can probably be cured from your cancer, but you will get an infection. And there's a 1 in 3 chance, he's saying to patients, that you'll get an AMR that I can't treat. The moment that goes too high, I don't know what level it goes too high, I might prefer my bucket list and palliative care to the unpleasantness of the treatment and the risk of an infection that's untreatable. So they're not protecting their product lines either, which I think is really interesting and silly.
Last question for you, Sally, and it's from Marta, who's online. And hello, Marta. who asks, could you speak more about how we build a national health service as opposed to a sickness service? How do we create an institution that promotes a healthy lifestyle? I mean, I remember waking up listening to the radio a few years ago, Sally, and I think it was when you were chief medical officer, but I heard you in a rather stern voice saying that we shouldn't drink, was it fizzy drinks and eat chocolate bars on the train? And I remember thinking, well, hold on, you know, I might want to drink my chocolate bar and take the health disbenefit. Where do we, how do you envisage what it is that, particularly for us here in a School of Government, what is it, how far should the government intervene, and with what rationale, given that you want to preserve some choice for people and not be accused of a nanny state, but at the same time, you don't want the government bankrupting itself trying to care for people that have made poor life choices. How do you navigate that?
So you've fallen into the trap that nanny states are bad, but we'll leave that on one side. I mean, nannies can be very good. What we have to do is shift so that the easy choice is the healthy choice. Mm-hmm. And when I did a report, which came out in October 2019 on obesity, what I was helped to see was how, particularly for children, they're sat in a flood of unhealthy food and drink coming at them. It's in the spotlight. So having choice doesn't mean it shouldn't be available, but how is it that we've let it be the easy thing? And we need to shift both by financially, and I think the soft drinks industry level is fascinating. The idea came from the Treasury, and they modeled it and thought they'd make quite a bit of money. But actually, the companies, most of them did reformulate, so calories were saved, and their sales went up 10%. So through different things, there are ways to make the easy choice the healthy choice, but we're going to have to go back to smaller portion sizes, greens and fruit and bread, wholemeal bread, much more easily available in the supermarket, much better priced, and making the unhealthy foods less easy to access, not taking them away, but making it less easy. I mean, all this from the chocolate manufacturers, have a barter share. They know you're not going to share it, you're going to eat it all. We've got to move past that, because actually that's what makes people overweight, gives them diabetes, and then when they catch COVID, they die. I mean, we've had the biggest wake-up call ever that we've got to do something.
Mm-hmm. So, Sally, let's end on a positive note. You early on in today's conversation, you talked about the report that looked at health in 2040. What was the happiest bit of that snapshot of our lives in 2040 that you could leave us with?
I think for me, it's of course the potential of science and society coming together to make the easy choice the healthy choice, but also to have lots more vaccines and ways of protecting us from illness.
Well, look, Sally, from all of us here and from everyone online, a huge thank you for spending this time with us and taking us across this wonderful breadth of the world of health. I want to finish by just again mentioning your book, Whose Health Is It Anyway? Oxford University Press. It's out, it's short and readable, and I thoroughly recommend it. And a huge thank you to Sally Davies for joining us here tonight. Thank you, Sally.
Thank you.
Oh, I can't pull this off.